afternoon, everyone. On behalf of Medicine Unit 1, I welcome you all for today's CCR, which we've titled as Fleeting Power, a puzzling case of weak muscles. The case will be presented by Dr. Kenneth, junior resident, and discussed by Dr. Sandeep, our senior resident.
Good evening, respected faculty and dear colleagues. So I'll be presenting the clinical combined rounds for Medicine Unit 1 today. We had a 26-year-old female who presented to us with repeated attacks of weakness of all four limbs for the last 3 years. She also had difficulty in walking and climbing stairs since the last 1.5 years. And the repeated attacks of weakness used to occur once in 1 to 2 months. They were painless and severe enough for the patient to be bedbound. There was no loss of consciousness, abnormal limb movements, incontinence, confusion, or dysphagia associated with them. There was history of multiple hospital admissions and resolution of this weakness with some IV and oral medications. During each such episode, she would go home walking by herself and she would function normally in between attacks until about 1.5 years ago. After which she developed a gradually progressive difficulty in walking, standing up from sitting position and climbing up and down the stairs since 1.5 years, which was insidious in onset, associated with generalized body pains, persistent and interspersed with attacks of episodic quadriparesis as previously described. On further probing over the last 3 years, she also had subjective low-grade fever, loss of appetite and gradual weight loss, along with on and off dry cough. There was no history suggestive of proximal upper limb weakness or weakness of the distal muscles of the upper or lower limbs. There was no history suggestive of bulbar dysfunction or extraocular muscle involvement. There was no history of incontinence or constipation. There was no history of any sensory complaints. There was no history suggestive of cranial nerve involvement or autonomic dysfunction, seizures, loss of consciousness, dyspnea, chest pain on exertion, and there was no history of genitourinary or gastrointestinal tract complaints. There is no history of inflammatory type of joint pains, photosensitivity, Raynaud's phenomena, Sicca symptoms, alopecia, chronic vomiting, diarrhea or pain abdomen. There is no history of weight gain, stry over skin or easy bruisability. There is no history of palpitations, anxiety or passage of any reddish brown urine. The weakness did not have any diurnal or exercise related variation, and there is no history of alternative medicine intake. Her past history, personal history, drug history and family history were not significant. She was admitted for the evaluation of persistent proximal muscle weakness in a background of a periodic paralysis-like syndrome. So on examination, she was found to have tachypnea at 32 breaths per minute. Pallor was present along with oral cavity examination revealing multiple carious teeth with a normal sublingual salivary pool without any dental overcrowding. There were no tender or swollen joints. However, a hyperpigmented macular lesions were noted over bilateral lower limbs as seen in this photo. On probing the patient showed these photos that she also had recurrent crops of erythematous rashes over the bilateral lower limbs which used to heal by themselves. These lesions are erythematous and macular on bilateral lower limbs, which raise the suspicion of a palpable purpura-like lesion and a suspected cutaneous vasculitis. However, a biopsy could not be done as during the hospital admission there was no active rash present. So, neurological examination revealed a waddling type of gait with normal sensory, cranial nerve and cerebellar examination. Motor examination was remarkable for hyperreflexia with a normal bulk and tone of all four limbs. Power examination revealed a proximal weakness which was more marked in the lower limb muscles than the upper limb muscles. Chest auscultation revealed fine end inspiratory crepitations on the left infraaxillary area. CVS and abdominal examination were unremarkable. So summarizing the case, she was a 26-year-old female with recurrent episodic quadriparesis, persistent lower limb proximal muscle weakness, recurrent crops of erythematous lower limb rash and constitutional symptoms, which on examination revealed pallor, dental caries, hyperreflexia, a waddling gait, lower limb predominant proximal muscle weakness, inspiratory crepitations and tachypnea. So routine workup was done for the same, which revealed anemia with high MCV, that is macrocytic anemia, a low calcium and phosphate levels, along with high alkaline phosphatase levels and a low potassium level. Thyroid function test was normal. So approaching episodic weakness, if a patient presents to us with intermittent weakness in the presence of passage of reddish brown urine and exercise related muscular pain, we should consider storage disorders. And if there is a diurnal variation in weakness along with ptosis or extraocular muscle involvement, neuromuscular junction disorders should be considered. If the examination is normal in between attacks and there is a presence of abnormal facies or an ECG, Anderson-Tavil syndrome, which is a primary periodic paralysis syndrome, should be considered. Others include myotonia, paramyotonia congenita, and hyperkalemic periodic paralysis, where potassium is elevated and myotonia is seen on examination. If there is low potassium during the attacks, a low TSH level, and thyrotoxicosis like symptoms, we should consider a diagnosis of thyrotoxic periodic paralysis. But our patient had a normal TFT, which makes this less likely. And if the potassium is low during attacks and there is no myotonia, we should consider the patient to be having a hypokalemic periodic paralysis. So reviewing the lab records in our patient, it showed that she had hypokalemia during the previous hospital admissions for which she was treated and muscle weakness had resolved. So hypokalemic periodic paralysis can be of two types, primary or secondary. In primary cases, the potassium is normal in between the attacks without any associated acidosis or alkalosis. And in such cases, primary hypokalemic periodic paralysis can be confirmed with a DNA testing. If there is hypokalemia in between attacks and an associated acidosis or alkalosis, we should consider a secondary cause for hypokalemia, which include hyperaldosteronism, chronic diarrhea, renal tubular acidosis, or drug abuse. So VBG was obtained in our case to differentiate between a primary and secondary cause, which showed a metabolic acidosis with a normal anion gap and hyperchloremia. So for evaluation of a normal anion gap metabolic acidosis, she did not give any history of GI losses. So a urine workup was done, which revealed that there is a positive urine anion gap along with an alkaline urine pH. So this was suggestive of a renal tubular acidosis. Urine routine microscopy did not reveal any glycosuria, and there was pyuria, but the culture was sterile, and proteinuria was seen without any albuminuria. That is a mild non-selective proteinuria along with sterile pyuria was seen. So in the setting of cutaneous vasculitis like rashes and renal tubular acidosis, a suspicion of tubulointerstitial nephritis was also raised. But a biopsy was again not done for the same, as the proteinuria was only mild. So to delineate the type of renal tubular acidosis in our patient, first we look at the proximal tubular function. In our patient, there was no glycosuria or hypouricemia. Although hypophosphatemia was seen, it was not seen on repeat evaluation. Next, we look at the potassium levels. If the potassium levels are high, we make a diagnosis of a hyperkalemic or type 4 RTA. In our case, the potassium level was low, that is 3. So next we check the urine pH, and which was 7 in our case. So an alkaline urine with a low potassium confirms the diagnosis of type 1 or distal RTA in our case. So major causes include familial, and there is no family history. There is no history of drug intake. Serum calcium was low, which is typically high in sarcoidosis, hyperparathyroidism, and vitamin D toxicity. USG ultrasound abdomen was normal, so structural causes can be ruled out, and there is no neuropsychiatric or complaints on a normal LFT, so Wilson's disease becomes less likely. So we evaluated further for autoimmune conditions leading to type 1 or distal RTA. So autoimmune profile came to be strongly positive for ANA, anti-SSA and anti-SSB with non-specific rheumatoid factor positivity. In view of this autoimmune profile, exocrine gland function was checked to establish a diagnosis of Sjogren's syndrome. And Sherman's test was 20 mm in bilateral eye, and Sika ocular staining score was 0, and which indicates that there is no evidence of ocular Sika. Salivary scintigraphy was done to evaluate for salivary gland function, and I'd like to call Dr. Yamini, SR Nuclear Medicine, to discuss the findings of this.
Good afternoon, everyone. The salivary scintigraphy of the patient reveals normal tracer uptake in both with normal extraction and clearance in left gland, with impaired clearance, extraction and clearance after stimulation in right gland, bilateral and mandibular, which is consistent with the Sjogren's syndrome. Thank you.
So, as the salivary scintigraphy confirmed the diagnosis of xerostomia. For evaluation of anemia, retic count was high with a normal nutrition profile, a positive direct Coombs test, and a high IgG levels without any M-band on electrophoresis, with peripheral smear showing 5% spherocytes. A diagnosis of autoimmune hemolytic anemia with polyclonal hypergammaglobulinemia was made. So for evaluation of the hypocalcemia, we did a vitamin D and IPTH levels. Vitamin D was low, but although IPTH came out to be normal. A 24-hour urine calcium create ratio was more than 0.2, indicating that she is losing calcium in her urine, which is consistent with a diagnosis of distal RTA. Although phosphate was low, repeat values were normal, and a TMP GFR, which is used to look for the renal wasting of phosphate, was done, which was also normal. So there was no renal phosphate wasting, and X-ray also did not reveal any changes of metabolic bone disease. So for dry cough and crepitations, we obtained a PFT, which revealed a restrictive pattern. And in the setting of a background autoimmune-like disease, a suspicion of interstitial lung disease was raised. A chest X-ray done for the same did not reveal any significant abnormalities. So, since our patient has autoimmune hemolytic anemia, cutaneous vasculitic rashes, and a renal tubular acidosis, could this be a case of systemic lupus erythematosus? So if we apply the 2019 ACR Euler criteria for SLE, she meets the entry criterion and at least one clinical criteria, but only total 6 points are done, whereas the diagnosis of SLE requires 10 points. And if we apply the criteria for primary Sjogren's syndrome, she has anti-Rho positivity and impaired salivary gland function. So a primary diagnosis of primary Sjogren's syndrome was made. So in our case, it's all in the potassium. For the patient presented to us with periodic paralysis, which was on evaluation was found to have recurrent hypokalemia, which was due to distal RTA caused by an underlying primary Sjogren's syndrome. So the fleeting weakness for 3 years, that is a periodic paralysis, can be explained by the secondary hypokalemic periodic paralysis. But what about the waddling gait and the persistent proximal muscle weakness? What could be the cause in our patient? It could include the autoimmune inflammatory myopathy in the background of Sjogren's syndrome, a hypokalemic periodic paralysis related myopathy, where due to repeated attacks of hypokalemia, patient may develop persistent fixed weakness. And could it be something else entirely? So if in cases of autoimmune inflammatory myopathy, an EMG would reveal signs of electrical irritability, and a needle EMG was obtained in our case, which was normal. And muscle MRI reveals signs of muscle inflammation. Now I'd like to call upon Dr. Ankit, SR Radiology, for discussing the MRI muscle of our patient.
So on MRI, these are T2-weighted images. We can see that there is diffusely reduced bulk of bilateral gluteal muscle. These are again representative images showing the same. So there is diffusely reduced bulk of bilateral gluteal muscle, which can be seen on T2-weighted. Moving on to fat suppressed images of T2-weighted, fat suppressed T2-weighted images. Seen in. It's not seen better. Start with this. So on T2-weighted images, we can see that there is diffusely decreased bulk of bilateral gluteal muscles. These representative images are showing the same. Moving on to fat suppressed images. Again, we can see that there is no altered signal intensity of bilateral gluteal muscles. So that will rule out active myositis in this patient. And this is a DW image, representative image, again showing no altered signal. This is a T1 weighted image, which shows again that there is diffusely decreased bulk of bilateral gluteal. So on MRI, there is bilateral gluteal atrophy with no evidence of active myositis.
So could it be, since there was no evidence of myositis and only diffuse atrophy in the MRI, could it be hypokalemic periodic paralysis related? This progressive myopathy usually manifests after the age of 50 years in patients mostly with primary type of hypokalemic periodic paralysis. An EMG long exercise test can be done where if there is a more than 40% increase in action potential after 5 minutes of exercise, a diagnosis can be confirmed, which was negative in our case. So this was also ruled out. Meanwhile, for the constitutional symptoms and unexplained restriction of PFT, a CCT chest abdomen was done to rule out infection and interstitial lung disease. I'd like to call upon Dr. Ankit again to reveal the surprising findings of the same.
On soft tissue window of CECT abdomen, solid organs were normal. There was no ascites, there was no pleural effusion. However, on lung window, we can see that there are some reticular opacities which are seen in the basal segments of left lower lobe. This likely represents past sequelae of past infection. However, moving on to bone window of this patient, we can see that there is a radiolucency that is extending from the medial cortex of the left femoral neck, not reaching up to the lateral cortex. This is likely a pseudo fracture or loser zone that is involving the left femoral neck. This was seen on the right femoral neck as well. This is an MPR image which is showing axial, sagittal, and coronal images showing the loser zone. And again, there are multiple pseudo fractures involving bilateral ribs, representing pseudo fractures of bilateral.
Thank you, Dr. Ankit. So I'd like to stress again that the pseudo fractures were seen only on the bone window of CT scan, and the X-rays were normal. So these fractures reflect impaired repair of bone after injury, and they are not exclusively found in osteomalacia, but in the presence of a compatible clinical syndrome, they are usually sufficient for the diagnosis of osteomalacia. So on evaluation for the same, IPTH level was sent again in a cold chain, which came out to be high, and thus a vitamin D deficiency with secondary hyperparathyroidism and a reduced bone mineral density on a DEXA scan confirmed the diagnosis of osteomalacia. So in our case, osteomalacia was due to two underlying mechanisms. First is chronic acidosis, which stimulates the osteoclast and suppresses the osteoblast, which leads to increased bone turnover, and the anions released for the same act as buffer for the chronic acidosis. Low vitamin D leads to secondary hyperparathyroidism and defective mineralization, which causes osteomalacia. So this was a dual mechanism of osteomalacia in our case. So could this explain the weakness in our case? Osteomalacic myopathy is a well-described entity, and osteomalacia itself is a common cause of waddling gait and hyperreflexia. The proximal predominant weakness is the initial symptom of osteomalacia in about 30% of cases. It is often a painful condition with normal CK levels, and mostly the EMG is also normal. And histopathologic findings are also non-specific, but may include type 2 muscle fiber atrophy, although biopsy is not indicated for the diagnosis. So what's up with the chest? As we saw that there were fibrotic bands in the left lower lobe, which can explain the focal crepitations. The bilateral rib fractures are responsible for the restrictive pattern seen on the pulmonary function testing. And xerotrachea, that is the dryness of the airway due to infiltration by autoimmune in the underlying Sjogren syndrome, can lead to a persistent dry cough. So a final diagnosis in our case was made of osteomalacic myopathy due to vitamin D deficiency and distal RTA, along with secondary hypokalemic periodic paralysis due to distal RTA and primary Sjogren syndrome manifesting as AIHA, cutaneous vasculitis, a distal RTA, xerostomia with dental caries, and xerotrachea. She was started on potassium citrate syrup, 10 ml thrice daily, and soda bicarb tablets for the RTA, and vitamin D and calcium carbonate supplementation for the osteomalacia. For autoimmune hemolytic anemia, she was given glucocorticoids at 1 mg per kg per day and rituximab as the steroid sparing agent, along with dry cough, for which she was given steam inhalation. Tachypnea resolved with the correction of acidosis and potassium. Cough resolved with steam inhalation. Full muscle power was regained and gait had normalized within 3 months. This time period of response is consistent with osteomalacic myopathy. The hemoglobin levels have reached near normal levels and the proteinuria has completely resolved. Now I'd like to call upon Dr. Sandeep for a discussion on the same.
Thank you, Kenneth. So muscle weakness in osteomalacia. The earliest description of this is postulated to be to date as far back as 400 AD by Vagbata, where he mentioned that there is excessive and constant pain of the hip bones, great loss of strength, and increased porosity of the bones in a patient. If you look at the cases that have been published, initially in 1949, it has been noticed that muscle weakness is a symptom of osteomalacia, and the largest series that was published in the 1960s and 70s have published an incidence of 40 to 50%. So about half of the cases of osteomalacia present with weakness, that is proximal weakness. Bone pain is the most common symptom, and deformity, waddling gait, and tetany occur with variable frequencies. But the term osteomalasic myopathy as a distinct entity was described first in 1979 because there was a characteristic feature that was noticed in the muscle biopsy of these patients. So this is an image of the gluteus medius muscle showing atrophy of the type 2 muscle fibers. So this was described, and this about 1/3 of the cases with osteomalasic myopathy have been shown to have type 2 muscle atrophy, while there can be non-specific findings as well. This is the largest case series on osteomalasic myopathy from India. This was a 10-year retrospective data from a center in North India. Most of the patients belong to less than 20 years of age, the child age group, and 50% of them have risk factors. Risk factors for vitamin D deficiency, including anti-epileptic drugs which interact with the metabolism of vitamin D. They also had malabsorption syndromes which interfered with the absorption, and they had trisomy 21 and also certain other risk factors. So 4 cases presented with hypocalcemic seizures, while most of the other cases presented with proximal myopathy. All patients underwent a full recovery after treatment. This is a case series from Department of Neurology, Mar Institution. 10 cases were published, and all these 10 cases were seen in a span of 1 year. And it was postulated that it was likely due to lockdown, closure of schools, and travel restrictions that were placed. This led to vitamin D deficiency, a spike in the deficiency, and a spike in the cases of osteomalasic myopathy. Interestingly, there was one case seen in an adult. He was 31-year-old male. He was a resident doctor posted in the ICU for a continuous duration during that time. He presented with proximal myopathy. He was diagnosed with osteomalasic myopathy, and he improved after 3 months of treatment. So if we look at the other characteristics of the patients seen here, 50% of them presented with bone pain. About 1/3 of them had hyperreflexia. Almost all the patients had normal muscle enzymes. The electrolyte abnormalities were seen in most of the patients, that is disturbances in calcium and potassium and raised DLP. Secondary hyperparathyroidism was present in all the cases, and X-ray abnormalities were seen in about 3 cases out of the 10 cases. So this is a review from CMC Vellore, where they looked at a large cohort of Sjogren's patients and assessed the incidence of RTA and osteomalacia in such patients. So 380 clinically diagnosed Sjogren's patients, and out of them 25 had RTA and 9 patients had osteomalacia, all of which had RTA. So here we can see that the incidence of osteomalacia is quite low, and among these patients it was not exactly noted how many of them presented with proximal myopathy and what was the frequency of myopathy in such patients, although 9 of them did have osteomalacia. 64% of the patients with RTA, it's also notable that they had either a current or a past history of hypokalemic periodic paralysis. Now, if we look at a presentation that was similar to our case, Sjogren's, RTA, and osteomalacia. So, or with osteomalacia being the presenting, the musculoskeletal manifestation being the presenting feature. So, only 7 such cases have been reported so far, and only 2 of these cases which have been highlighted have had myopathy as a feature, while the others have had articular manifestations. So how does vitamin D deficiency exactly cause proximal myopathy? So vitamin D has a direct effect on the muscle cell via the MAC-PK pathway, and downstream calmodulin and IGF are the mediators. Vitamin D directly improves muscle contraction and also promotes the proliferation of type 2 muscle fibers, thereby explaining the specific histopathological finding that is seen, that is type 2 muscle atrophy in vitamin D deficiency. Coming to the extraglandular manifestations of Sjogren's syndrome, it can be myriad. It can happen in 30 to 50% of the patients. And interestingly, a lot of these patients, a significant number of these patients may present without any sicca symptoms initially. So they may present to any department. In our case, we had musculoskeletal, dermatological, and renal manifestation, but it can affect any organ like the lung, the GI tract, or the heart. Renal involvement most commonly presents as a tubulointerstitial nephritis, which can progress to CKD. The next common manifestation is distal RTA, followed by even some cases of proximal RTA have been noted in Sjogren's disease. Isolated electrolyte disturbances can also occur, Quite rare is glomerular diseases, and of course, with distal RTA, we can have nephrolithiasis and nephrocalcinosis as well. Our patient had AIHA, but most commonly normocytic normochromic anemia is seen in Sjogren's disease. But 2.8% cases can have AIHA, and this was noted in a series of 565 patients. And interestingly, 3 of the 16 cases did not have any Zika symptoms on presentation. Cutaneous vasculitis can occur in approximately 4 to 10% of primary Sjogren's patients. Small vessel vasculitis is the most common and it presents as a palpable porphyria, although it can also have other manifestations. The types include cryoglobulinemic or hypergamma-globulinemic, and the cryoglobulinemic form can have a prognostic significance as these patients can later develop lymphoma. Touching upon the treatment of RTA, we initially correct the hypokalemia followed by alkali replacement. It is given in a dose of 1 to 2 milliequivalent per kg per day in 2 to 3 divided doses, and it is titrated till the serum bicarb normalizes. What is the role of immunosuppression in RTA? Immunosuppression is postulated to reduce the interstitial inflammation that is seen in tubular interstitial nephritis, and it is also postulated to suppress autoantibody production. But the the clinical data that we have is scarce, but definite improvement in GGFR has been noted in patients having tubular interstitial nephritis. While in RTA, the data is mixed, but there have been certain cases that have benefited. In one such case report, what was used was glucocorticoids and rituximab. So how do we treat osteomalacia? Vitamin D and calcium supplementation. Calcium at a dose of 1 to 1.5 grams per day, and vitamin D 60,000 international units per week for 8 to 12 weeks. And then a maintenance dose is given with the goal being normal PTH levels and a 25 hydroxy vitamin D level above 30 nanograms per ml. So to conclude, things are not often what they seem. Our patient walked in with muscle weakness and a waddling gait, but ultimately she ended up being diagnosed with a multi-system disorder with underlying Sjogren's syndrome. So I would like to thank these various departments for their contribution to this case. Now I would invite Dr. Siddharth sir to conclude and give the learning announcement.
So for want of time, I would just invoke a famous aphorism that goes that not every Sjogren's is Zika and not every Zika is Sjogren's. So it's very important for us to understand that Sjogren's is can present to any specialties. So in the rheumatic circle, Sjogren's is called as a great imitator because of the virtue of its extra granular manifestations can present to any specialty. And since these patients may not have Zika, either subjectively or objectively, it becomes very challenging to diagnose them unless we keep a high threshold for diagnosis. Important passages were hypokalemic periodic paralysis, think thyrotoxicosis, think distal RTA. When you think of distal RTA, think Sjogren's. And most importantly, since patients don't really come with a diagnosis on their face, it's very important to really pick up those soft, subtle points on history and those on examination so that we can actually finally clinch a diagnosis. Otherwise, patients will go around presenting to various specialties with various diagnoses and would probably be mismanaged. With that, I would like to sum up and open the house for comments, suggestions, and experience of the house. Thank you. So we had ruled out renal phosphate wasting through TMP GFRs. So we had worked up along those lines. When we look at osteomalacia, it's either vitamin deficiency or hypophosphatemia related. Serial phosphate records were reporting normal, only one report of abnormal, and we looked at phosphate wasting and we ruled that out. Yes, sir. Everything was Sjogren's, sir. So Sjogren's, one of the most common manifestations, renal manifestations of Sjogren's is tubular acidosis. It can be distal, can be proximal. So it was all. Yes, sir. So one of the common. The distal RTA would be a syndromic diagnosis, sir. As far as the etiologies of distal RTA is concerned, as we showed in the table, so as far as the known etiologies are concerned, we rule all the other. So, sir, the syndromic diagnosis would be distal RTA, and we look at all the various etiologies which can possibly occur to rule out the concomitant illness. We ruled out the other causes, and then focused on the. So yes, that's the most important treatment, but a lot of people have found that distal artery, which happens in the setting of autoimmune diseases, responds to immunosuppression. There is report of use of glucocorticoid and rituximab, which we are given in this case for the autoimmune hemolytic anemia part. But as we saw on follow-up, the proteinuria also resolved. So how much of it is actually acting at the distal artery level in autoimmune diseases remains a subject of question, because the pathogenesis is slightly different as per may be associated with the tubulointerstitial nephritis. Yes, sir. So yes, sir. So the ideal way to say that the immunosuppression is responding distal artery would be if we are able to wean off the alkali and the potassium. So if the patient gets off alkali potassium, we'll say that the distal artery has been cured, which has not happened. We need more prospective data. Yes.
Supporting